Paul, that's a great question. Actually, I think John described it in his earlier remarks, in that we need agile constructs that are appropriate for transitioning towards from what we can do now to what we want to be able to do, setting the bar high in the future. He was exactly right in describing how useful blobs of text can be right now in improving continuity of care. And that would be a dramatic demonstration of capability. And I think Bob really was nailing it when he talked about the number of interfaces that a single network can handle on behalf of all of the participating nodes. The network effect is going to rule in the long run. The only question I have is whether we're going to pay attention to planning for it in the beginning, or whether we're going to be dragged into it by economics in the long run.
I think overall we need to have a practical and achievable path. I mean, a phased approach to get to whatever level of meaningful use makes sense, even to academics, is okay. But it's got to be achievable. If in your own bonus program, if they ask you to jump over the building, you don't even try. If they ask you to jump over the car, well, you'll try and do that. You'll injure yourself doing it. That's where we need to be. It's got to be something that they can look at and say, that is a step that is reasonable for me to take. I know that I have to go down here. Okay? I know that I have to ultimately move to this level, and this is a path, a step, a process that will get me closer toward it, and hopefully will get me rewarded along the way in a phased approach.
I think the work we're doing with the patient-centered medical home and the recognition process may have some applicability here. We define 3 different levels. We define that first level as sort of to get folks in the game, not to disenfranchise the small practices, but to get them to do something distinctly different than was common. But the goal is that level 3, the highest level of the medical home, which has the robust technology. I think the idea that each incremental step comes with incremental rewards that offset the costs of moving that way, so you actually create that roadmap or cookie crumb trail, whatever you want to call it, so the practice is moving in the direction we want. So I think that would be a viable strategy to consider.
So I guess I mean, I don't know how much disagreement there really is here, but the thing that I would just say is that to Bob's point, I think that there's a tension. If the constraints are drawn such that we're saying that it has to be achievable, but it has to be achievable for the doctor in Cincinnati and the doctor in rural Alaska, and by 2011 and by 2012 the door shuts and that's it. Right? And I think that staff who are focused on this are appropriately concerned with the equity part of that, but because they have to be because of those constraints. But that equity, focusing on that equity leads us to the lowest common denominator, where what's achievable then becomes what's achievable in rural Alaska, and doesn't take advantage of all the great stuff that Bob has done in Cincinnati. And that's and that's why, to me, we start to think about where we've even seen in the Regional Health IT Extension Center guidance that came out. They're talking about phasing it over a year, at least, to recognize that there are some places that have more capability right now, and those might get funded earlier, and then they get phased over a year. Now, that was all, I assume, within the regulatory authority they thought they had, and perhaps they would have broadened it if they thought they had more regulatory authority. And I'm just suggesting that, with that same sort of focus in mind of thinking about who is able to achieve more right now, and then, giving others a break so that they can get to a point where they can achieve the high bar. But let's not give up on having a high bar, because then we're, at the end of the day, we're just going to end up at, the Blackford Middleton level 3 and not be able to accomplish what we want to accomplish.
Excellent, if not totally sobering presentations. The question that I would have is given that there is some support in the regional extension centers, how much are they going to help? Will it end up, a net effect, hurting the effort because there's not enough resource there? Are the expectations too high? Can you give us your vision on the role that the extension centers will really play?
So I can start. all of it can't be accomplished by the regional health IT extension centers, right? I mean, nor should it be. I think we would probably all agree that that it shouldn't be. But I think that the way it's funded and structured right now, it couldn't possibly be. If you think about the amount of money we're talking about, there's $2 billion, well, 1.7 if you take out the $300 million for health information exchange that's discretionary to ONC, and then there's a whole bunch of stuff that needs to get funded in there. One part of which is the regional health IT extension centers. So I think there's a limit to how much money there's going to be made available to them, and then the way they're structured right now, I think it'd be very hard for them to be effective. And the reason I say that is, if we were to become one, for example, let's say at the Mass Health Collaborative, we would get a certain amount of money to do, some type of implementation support that, that may or may not be specifically defined. We don't yet know. With priority areas given to safety net hospitals and a variety of things that are given there. Most of the money is going to the physicians directly, so we have no ability to try to get more money except for going out and trying to sell services in a model where the physicians are having to pay up front and then they're getting their money later. So they're taking a lot of risk during the implementation phase. It's their money, and we're trying to convince them to to pay us for services that they don't really appreciate right now anyway. They don't really understand. And at the same time, we'd be given a relatively little money for what could be, potentially very, very high demand group of institutions who don't have a whole lot of resources on their own, who are, for lack of a better term, start getting into a competition for how can we take advantage of the regional health IT extension center before they run out of money, right? And I was in New York at a meeting of hospitals yesterday where that was explicitly the conversation. When that money comes, how do we make sure that that my hospital gets it before they run out of money, because they know that it's only 4-year money, 2 years blocked, with too little money for what needs to be accomplished. So that's the part that I think is still a work in progress in terms of figuring out how that business model is going to work. Right now, it doesn't feel like they're sustainable at all.
So for the people on the phone, Laura Adams asked a question of Micky Tripathi, and if we could announce your name ahead of time.
Okay. This is Bob Steffel. Just a quick comment on the regional HIT centers. Early on, we didn't have very much funding to throw at training, and even in the deployment of the EMR Lite, we used to do what we would call drive-by implementations, where we basically do the very basics of setting it up and making sure that they understood how to get in the system and use it in a very rudimentary way, and then we'd go on to the next one. And that actually worked a lot better than we thought, because it takes a period of time for people to get up on any kind of system, adjust to it, and then move on with it. This isn't going to apply as directly to an EMR, but the notion of having that money spread over a period of time and really being able to support it, even to measure meaningful use and come back and give feedback, I think would be useful.
Other questions, Kevin?
Well, I really enjoyed the presentation because I'm a huge fan of the incremental approach toward the EHR. We all want to get to the EHR, but I share the concerns about throwing a lot of money at standalone systems that aren't interoperable. And I've dealt a lot with especially small to medium-sized physician practices over the years on a variety of different interoperable things. And thinking back on the original billing out SureScripts and the e-prescribing network, we started with a single transaction type, new prescriptions and renewals, and then Change RX and medication history and eligibility and formulary. And these are all additive transaction types, all under the umbrella of what we call, e-prescribing. And it's interesting, as we start dealing with individual physicians, what business models right now need to be generated in this incremental approach as we try to define meaningful use of an EHR. It's great that money is going to be allocated toward the adoption of this, but outside of that money, what does the panel see as being the various different business models? And I've heard the word light EHR thrown around quite a bit for these light EHR services that the physicians use. Our current company, Informatics, focuses on health plans to help fund some of these activities for interoperability for small to medium-sized practices. And I'm just curious from the panel's perspective what various business models you see exist at the regional levels for the delivery of these kind of light EHR services.
This is Bob Steffel. I can certainly talk to that one. The model that HealthBridge has used is to really bring together the customers within a medical service area. Very important, because to the extent that you're going to use market pressure and market influence, it has to be in an area where the market will respond. Once you can get a critical mass of data within a market, then you can really move the entire market forward.
From the practice perspective, it has to solve their day-to-day business challenges, their office challenges. One of the concerns we had with some of the early definitions of EHR Lite, this is Michael Barr, by the way, and not to disagree with Bob about what he described, which I think is very valuable in the practice, but some of the efforts to sort of take what is meaningful use and make that the core function. And it seemed to me and to us that some of the proposals were ignoring some of the day-to-day functions. So we provide folks who can do things about meaningful use, but what are all the other things they need to do in their practice? So you give them a tool that just does meaningful use and doesn't deal with the day-to-day documentation, the inter-office communications, the practice management systems, all those kinds of things. So I think the solutions that Bob is providing and others, married with recognition of what needs to take place in the practice and achieve meaningful use on a roadmap to get us there over time, sort of the stages that Micky was talking about with the goal. I agree with Micky in terms of different goals perhaps for different groups depending on their stages of readiness would be the best model, I think.
This is Micky Tripathi. So, well, I guess, and Kevin, to your question, I mean, I very much support sort of the move toward unbundling the EHR, and I've generally not been really supportive of EHR Lite, whatever that means. But to the extent that we're talking about now certifying specific functions, I think that will at least allow or take away some of the constraints that have been imposed on the market right now that that have essentially, from a regulatory perspective, almost dictated that the EHR has to be a certain thing, rather than saying let's just unpack this, certify functions, and that allows for a lot more innovation and a lot of different ways of thinking about packaging things together that could be cross-vendor as well. So I think that's a very healthy development. Maybe in the end that looks like an EHR Lite. I mean, I don't know what the answer to that is. But to your question about how these regional organizations could support different technologies, I think was kind of what you had said. I mean, to me, providing platforms is what they could be good for. I mean, we don't want them to be providing applications, but even when you think about a regional extension center that could, on the one hand, be providing professional services and then perhaps be able to be a hosting center, for example, a regional hosting center that could provide a lot of efficiencies over the long run. And I think that could be a very good model. When you think about the time frames we're talking about and the upfront investment that would be required for that, you're still hard pressed to figure out what that business model would look like for them to get established. I mean, I'm hard pressed to figure out how that would work. Maybe others, have figured it out, and I'm just going to be left behind.
Other questions, Janet?
For Bob, you indicated that HealthBridge is 97% of the revenues from fees paid for products and services, but you're about 12 years old. What was the total amount of grant funding or upfront capital investment that went in, say, in the first decade? You've now kind of reached that point where you're fortunately very successful in self-sustaining and have a business model that's working for you. But how long did it take to get there? What was the total amount of money?
Well, we had two problems. Initially, we weren't smart enough to know it couldn't be done, and we didn't know that anybody else would pay us money to do it. So we had to start the organization the old-fashioned way. The customers of HealthBridge actually gave us loans, not grants. We had 5 health systems, 2 health plans give us $250,000 loans. Early on, I was dismayed that these were loans and not grants, because each loan came with a board member to sit there and heckle me. Oh gosh, I didn't say that on tape, did I? But it turned out that the loans that came with somebody to sit at the table turned out to be pivotal. They were engaged. They had a fiduciary responsibility, and that ended up taking us down the path to be able to create the trust and the collaboration. Our annual budget now is right at $4 million. And this is 12 years later. So early on, we started with 3 people and that $1.75 million in the loans, two of which have been paid off, by the way. So it's the only significant grant that we've gotten to this point. We have others that we're getting ready to start on. Was really an effort to study us and figure out how we were self-sustainable. So very little grant interaction, even in our entire history.